Thank you very much, and I'd like to again say how honored I am to be here. And I know you guys were in this room yesterday, and Lisa and I were mainly in that room, but I thought the medical portion of this conference was phenomenal, and I think that you guys can leave here knowing that you have a lot of clinicians in this country who are very passionate about TSC and working together as a community to make everything better for everyone living with this. So what Claire had asked me to do is talk about signs and symptoms of the brain and TSC, and then Simone's going to kind of talk about some aspects of this from the Australian perspective. So why is this not working? So kind of just to start, I think as we talked yesterday, CNS involvement really is a hallmark of TSC, and it's seen in 95% of folks with the disorder. And Claire, by any chance, are there batteries? Yes, thank you very much. 30 years of education, I have trouble finding switches. So the pathologic features or the signs that we're going to talk about today go over the main ones are cortical tubers, subependymal nodules, and then subependymal giant cell tumors, or what are also called subependymal giant cell astrocytomas. And then as you saw yesterday in the new consensus guidelines, also this radial migration lines have been added. So I'm going to kind of show you what those are. So this is an axial MRI. So this basically is an MRI image we're looking up from the person's feet, and we're looking at axial images here. So what you see here is the front of the head, the back of the head, and then this is the brain. And kind of what you can see are these areas here of bright appearing or bright signal. Those are cortical tubers. And we're going to talk about tubers in a minute. And then this is the ventricle. So all of us have these two lateral ventricles in our brain. That's where the spinal fluid is made. The wall of the ventricle is called the wall of the ventricle, but the lining of it is called the ependymal lining. And what you see sitting right there is a subependymal nodule. So those are cortical tubers and subependymal nodules. So two of the major features in the brain. If you look at cortical tubers, they're located at the gray-white junction. What I could have pointed out was kind of in the brain you have the gray matter, which here looks lighter on this sequence. That's where the neurons are. So kind of during gestation, the neurons, which are big workers in the brain, start out in the middle of the brain and they migrate out in waves, end up on the surface of the brain. So that is the gray matter. And then what looks darker on this is actually what we call the white matter. And you'll see in a second it really does look white because it has high fat content. What the white matter is the neurons all have little connecting fibers called axons. And you can kind of think of them as telegraph lines. And largely after birth, a fatty protein cover called myelin gets put on that. And because of the fat content, it looks white when you look at tissue. So there is the cortical and then the subcortical or white matter. So tubers, as you can see here, are usually at the junction of the cortex and the white matter. They vary widely in size and distribution. And histologically, basically all that says right there is they're areas of the brain that develop unusually. So they're what we call dysplastic areas of the brain. We don't know why they form. Sometimes it's around 14, 16 weeks gestation when the baby neurons are moving out that tubers form. And we have no idea why they form. But the bottom line is since they form during pregnancy, the tubers a person with TS has, they're born with. They are not tumors. They're areas that develop unusually, so they do not grow. But as we can see, they can calcify and they can also undergo cyst-like changes with time. And then this is actually a pathological section of a tuber. And as you can see here is this, now you can see these are the gray matter or the cortex here. And then this area that looks white, that's the white matter. And as you can see here is this nice cortical ribbon. You come around here, you see it, and then here you lose it. And that's what a cortical tuber looks like on a slice of the brain. So then, as I already said, these are kind of different here are subependymal nodules. And subependymal nodules are different than tubers. So subependymal nodules are made of largely white matter. So not gray matter, they're not neuronal, they're white matter. And unlike tubers, they can grow. So this is one of the reasons that it's recommended that children under the age of 20, now 25, have annual or routine neuroimaging to monitor for the development of those. And if those grow, then they're referred to as subependymal giant cell tumor, or subependymal giant cell astrocytoma. This is something that we look for in childhood. For reasons that are not well understood, these things lose the propensity to grow after the age of 20. And the mean age of presentation is really 9 years of age. They, we think, come from those subependymal nodules. And they kind of like to grow What I don't have a good picture of is kind of the spinal fluid's made in the two lateral ventricles. Then it has to flow through a tiny little canal called the foramen of Monroe to the third ventricle, fourth ventricle, circulates around the brain and spinal cord and gets absorbed. And all of us make about a Coke can equivalent of spinal fluid per day. Where the subependyles really like to grow is right in the region of that little foramen of Monroe. And we think that's because they derive from the remnants of the germinal matrix, which are the cells that lead to all of the brain cells. And they are in that area, so that's where they grow. And if they grow in that area, then they can block the flow of spinal fluid. So subependyl giant cell astrocytomas are not malignant tumors. They're just tumors that grow, and they become a problem if they block the flow of spinal fluid, because then my brain would keep making spinal fluid, but it would be trapped and couldn't get out. So classically, the symptoms of this, with presentation like my friend Michael I told you about yesterday, are headache, vomiting, lethargy, and papilledema, but they can also be more subtle. And I've gotten to really respect these things over time. Sometimes kids will present with these just with an increase in seizure activity, a significant change in behavior, or more subtle things. Treatment has been surgical, but as we talked yesterday, kind of the mTOR inhibitors are now also FDA approved in the United States if surgery is not possible. And in the literature, it says that about a third of people who develop one of these will develop one in the other hemisphere. I don't really believe that's true. I think I've only seen that once. And as I said, the presentation can be really subtle. So this now is a coronal image. So this is looking at a brain this direction. And what you can see there is a large subependyl giant cell tumor that's extending into the third ventricle. So this child was put on rapamycin. And he's been on it now for 6 years because this was not surgically resectable without this child requiring a VP shunt. And then this radiomigration line. So this actually, my group has been really interested in looking at these. It's probably a little hard to see on this image, but what you can see in some of these areas is you can see a line of what looks like lighter fibers tracking through. And that now is one of the major criteria. And we've spent a lot of time looking at that, and there does seem to be a correlation between the number of these radiomigration lines, the number of tubers, subependyl nodules, and they're kind of related to seizure severity, et cetera. We're trying to figure out what radiomigration lines really are, because I think it would tell us something more about the brain, kind of what happens anatomically in the brain that results in cortical tubers and other features. So then turning from the signs or pathologic features of TSC to the clinical symptoms. And as I think you guys know, the main neurologic symptoms of TS are epilepsy, cognitive impairment, autism, and mental health issues. And we're just going to run through all of these pretty briefly. And like I said, Simone's going to come back and talk more about epilepsy management. So 85% of individuals with TSC will develop epilepsy. 70% the first year of life. So this is what leads to lots of children being diagnosed with having TSC, is that onset of epilepsy. And a third of babies with TSC will develop infantile spasms. So it's the highest leading cause of infantile spasms. You can have infantile spasms for a myriad of reasons: hypoxic ischemic injury, meningitis at birth, other disorders. But TSC is the most frequent cause. And if a baby develops infantile spasms for any reason, there is a significant risk of subsequent cognitive impairment, oftentimes profound. So actually one of the things that first got me really interested in tuberous sclerosis was this, because since so many of these kids get infantile spasms, the other important thing to know is that a third of those kids have a normal cognitive outcome, which surprises people. Here first you have TS, then you have spasms, and yet you have normal cognition. I take care of kids with TS who have had spasms, who have graduated from college, with IQs kind of higher than mine. And then vigabatrin, and Simone might talk about this more, but vigabatrin is known to be particularly effective. And in 2015, I think it is unacceptable for any child with infantile spasms in the setting of TS to be started on something other than vigabatrin. Unfortunately, they are, including in the United States. And then also epileptic spasms are also very common. So we've looked at this. Several kids that leave infancy continue to have spasms, and those can be hard to treat. They do not have the same impact on cognition that infantile spasms. And my oldest TS patient with spasms is almost 40. And every day he has episodes when he goes, which is a cluster of epileptic spasms. And then kind of when we looked at this in our population, 2/3 of folks with TS will develop refractory epilepsy. If you look at epilepsy in the general population, that's 1/3. And what refractory epilepsy is seizures which are not effectively treated by medications. In TS, it's 2/3, so a much higher portion of folks with refractory epilepsy. when we looked at this, kind of again, this is in our population, and really one of the values of having a large population, why I'm excited about the TS Alliance Natural History Database and the TSC databases, is you can learn a lot by looking at large populations of people with TS. So when we said, well, gee, what is the natural history of epilepsy and TS? If I have TS and epilepsy, is that a lifelong thing? We found it's not. It's not necessarily. And about a third of folks will develop long-term remission, and that includes 40% off treatment. And that also includes kids who've had refractory epilepsy, sometimes requiring epilepsy surgery, sometimes diet effectively controls their seizures. But many people with TS, once their seizures are controlled, are able to outgrow their seizures and cut off medication. We have a lot of new medications over the past years, and Simone will probably talk about this too, but our group has been particularly impressed about the efficacy of clobazam and lacosamide in TS, so much so that we wrote papers on that. I think oftentimes those are silly papers, but we thought they were pretty impressive. And then dietary therapy can be extremely effective, and I know Simone's going to talk about that, and that's one of my other passions that I'm real zealot about, is the role of dietary therapy. Vagus nerve stimulator can be effective, as can epilepsy surgery, and Simone's also going to talk about those. In the treatment of TS in epilepsy and TSC, anticonvulsant medications really continue to remain the first-line therapy. Seizures in TS are focal in onset by definition, so any of our medications could work. And there's anecdotal experience of efficacy in some of these drugs, in addition to our work on Vimpat or lacosamide and clobazam. There have also been reports about topiramate and lamotrigine being particularly effective. And again, vigabatrin, clearly the drug of choice, but vigabatrin is not risk-free, and there are side effects that we have to be cautious and respectful of. And if medications don't work, like we said, dietary therapy, vagus nerve stimulation, epilepsy surgery, and honestly, what I know probably many of you are interested in, what's been occupying most of my time the past couple of years, is the whole concept of medical marijuana. So at the end of this, I'm going to come back and talk in a little bit more detail about our experiences with that. But the real thing is that epilepsy is wicked common in TS, often very difficult to treat. And I think it's really essential to realize it's not just the seizures that are affecting people with tuberous sclerosis. And we and several other groups have looked at the relationship of epilepsy to the other neurologic symptoms. And the presence of refractory epilepsy and infantile spasms in TS, and also a mutation in TSC2, are all significantly associated with the cognitive impairment, autism spectrum disorders, the psychiatric disorders, including self-injurious behavior, and sleep disorders. And therefore, I kind of feel like knocked this into the ground, but it's essential. It's really important to get epilepsy controlled in folks with TSC. This is kind of some of the work we did years ago, and Patrick Bolton, who was here yesterday, his group has done similar work, that if you take a group of people with tuberous sclerosis, you actually find that there's a bimodal distribution of IQ, where about 50% of people, and this is also important because many healthcare providers don't get this, 50% of people with TS are completely cognitively normal. 50% have some degree of cognitive impairment, and sometimes it can be profound, sometimes it can be mild. When we looked at this, the folks that had the higher IQ were older when their seizures started. In fact, we don't have anyone in our group of now over 600 people that had seizure onset after the age of 6 who have any degree of cognitive impairment. Also, familial TSC, although that's a little bit skewed because familial TSC is often TSC1 mutation, and we know that that can be a milder phenotype. And then lower IQs were associated with current seizure activity, refractory seizures, mixed seizure types, and a mutation in TSC2. Then looking at autism, and I know every parent in this room, when they heard about TS and read about it and read about autism, became terrified that their child would be autistic. And so we've also looked at this, and other groups are actively looking at this. But when we looked at this years ago, we had 103 kids that our one neuropsychologist had evaluated, so very consistent evaluations, and 40% met criteria for an autism spectrum disorder. Now that really ranged to what we used to call Asperger's, to profoundly autistic, but in that range. And those with autism spectrum disorders were more likely to have a TSC2 mutation, much more likely to have a history of spasms, refractory epilepsy, more likely to have a lower IQ. Like we said yesterday, not more likely to be male, so that's different from the autism population in general. And we also looked, well, can we tell, is there a difference in tuber load, tuber number, tuber anything? And we did not find a significant difference with regard to brain involvement. If you look at the relationship of epilepsy to autism, folks that had tuberous sclerosis and autism spectrum disorders, again, epilepsy much more common. Spasms much more common. Earlier age of seizure onset, greater seizure frequency, and higher incidence of refractory epilepsy. So again, epilepsy is a very, very, very strong variable in the development of autism. And then we looked also at EEG features and found that there are greater epileptiform features in those with autism spectrum disorders than the other TS population, particularly in the left temporal lobe. And some of Patrick Bolton's work had also implicated possibly temporal lobe involvement with autism and TSC. And then a big focus we've had over the past 10 years now, because honestly, when I moved to the Mass General, in addition to taking care of children with TS, started taking care of adults with TS, was when I really became respectful of the incredible impact of TAND, or the mental health issues. And so we've looked at this in several different ways. Kind of looking, when we did, this was with a validated questionnaire, 66, or this actually is looking at our whole patient population, 66% had one psychiatric symptom. Over a third have more than one symptom. And the most common we see are mood disorders, anxiety, ADHD, aggressiveness, and disruptive behaviors. And then we looked at our adult population with a questionnaire called the SCL-90 that looks at several different domains of mental health. And found that folks with TS are at much greater risk of psychiatric disorders than the general population, particularly interpersonal sensitivities. Personal relationships are really, really difficult for many people with TS. Social alienation also adding into that, depression, and cognitive performance. And then one of the people that was entering stuff in our database came to me one day and said, "Gosh, Elizabeth, it looks like there's a lot of self-injurious behavior in TS." So she looked at that, and it's true. 10% of folks with TSC have self-injurious behavior, ranging from maybe knocking my head to really significantly injuring myself. And this can hurt. I had a little girl from Vermont, to age of 3, would pull out all of her eyelashes, all of her hair, and another kid that could really cause her nose to bleed faster than you could prevent her from hitting herself. Highly associated with the TSC2 mutation, history of spasms, seizures, cognitive impairment, and autism. So again, just emphasizing that relationship to all of these things to the epilepsy. The other thing we've recently found that I think is important from a care and treatment perspective, and as family members who have folks with TS, post-traumatic stress reactions are pretty common in TS. They often occur following mild stressors, so things that you think wouldn't derail somebody can often derail a person with TS, can significantly impact the individual's ability to function, and these typically respond to SSRIs, and we are now using different beta blockers to help with this. An example I can give, one of the families we take care of, they have a boat, they're often on the boat, kids grew up on the boat. One day she was on the boat, they have a big boat, and she had a seizure. She was in the room by herself, and for the first time she retained consciousness but couldn't move. Her mother was in the room with one of the other kids and heard this girl come blood-curdling screaming in because she was so terrified. Following that, she couldn't get on a boat. Kid who'd spent all her life getting on and off of boats couldn't get on a boat. And so we once identified that, then we could know how to handle that. Also, one of my autistic kids came in. He's one of the kids who had something we'll talk about later, pancreatic neuroendocrine tumor, but he came into the hospital. He tolerated the hospitalization much better than I thought he would. He was very calm, after he left the hospital, he went nuts. And he was in medical foster care, and his behavior got so bad that he almost had to leave his foster care parents, who really loved this kid. But once we heard about this and said, "Oh, we see this is post-traumatic stress," then we could effectively intervene. So anyone living with TS, I think it's important to realize that this can happen. Anxiety is almost universal, and the anxiety is different. Some people say, "Oh, you'd be anxious if you had TSC too," but it's not that. This predates the diagnosis in people. It's obsessive, frequently centered around specific things. And it's extremely underappreciated, underdiagnosed, and undertreated. So we are very proactive, because if you look in our pediatric, adolescent, adult population and ask people what is the thing most significantly affecting your quality of life due to TS, anxiety is high up there. So we are very proactive about looking for this and screening for this. And then one of the things we're currently really interested in, and I think anyone in the room could say, "Oh yeah, the person I know that has TS has a really good memory." Even the people with low IQs have really good memories. Well, that's always really intrigued me. And we also have a handful of TS folks who are savants, and we're looking at that. We have one girl who was completely knew everything about the U.S. presidents. She could tell you anything about the presidents, what years they were in office, who their wives were, who the left-handed presidents were. So I always have residents in the clinic, so I prepared them for this the next time this young woman came. walked in, and I said, Sarah, are you still interested in the U.S. presidents? Her parents go, nah, not so much anymore. And so then she was interested in film. The next time she came back, I had prepared the residents because this girl's so interesting to me. And she was no longer interested in film, now it was music. And you ask her anything about any song and she knows it. And her father said, Sarah, what year did Yellow Submarine come out? She said, 1971. And he said, or what, I can't remember the year, but she said, and he said, no, I think it was 1976. I, of course, Google searched it, she was right. And so then I thought, well, Sarah, do you still interested in the presidents? And kind of then she could still tell me the presidents in order. And her father said, what year was Theodore Roosevelt in office? And she could tell those years. Her IQ is 60. So there's something there about memory and TS. So this is a big area of interest for us now. And so kind of looking then at the big picture of TS, what causes epilepsy in TS, we honestly don't know. Can intractable epilepsy be predicted? And that's as, again, we're moving to that prophylactic treatment to prevent kids from developing this. Is there a role for prophylactic management? Why are spasms so common in TSC? Why do some kids with TSC and spasms have good cognitive outcomes? And really, what is the relationship between epilepsy and autism? And what a lot of people are doing now are thinking about, if you look at kind of the tubers, the seizures, the interictal discharges, so not the EEG, the kids seizing, but just the abnormal discharges, the genotype, TSC1, TSC2 type of mutation, and also is there a role for haploefficiency? Is there something just different about the brain of a person that has TSC? And looking at kind of trying to figure out cognition, behavioral, psychological issues, and autism. So kind of that's the big overview. And then, like I said, I will turn now to this whole role of cannabinoids in the treatment of epilepsy. And this is also very similar to the history of dietary therapy. And I think if you look at dietary therapy in this, it's fairly humbling that these are not new concepts. These are concepts that have been talked about for thousands of years. And so just looking really quickly at the history of this, cannabis has really been used for thousands of years. It was the first non-food crop yielding crop in China, and it was cultivated for garments, bowstrings, paper, and medicine. And one of the first references was in 2700 BCE, so a few years ago, where it was recommended for menstruation, gout, rheumatisms, malaria, constipation, other ailments. And then 1200 BCE, the Egyptians used it for glaucoma, inflammation, and enemas. And medical use is also documented in ancient India, Africa, Greece, Rome, and the Arab world. So pretty widespread utilization of cannabis and the treatment of different ailments. In epilepsy is actually first mentioned in Sumerian texts. These are stone tablets from 2200 BCE that cannabis was used to treat nocturnal epilepsy. And then kind of from the middle, this is Middle East now, these countries, 1100 nasal treatment of cannabis leaf for seizures, and then kind of more the regular use of cannabis for seizures. If you come more current times, in 1842, O'Shaughnessy reported cannabis reduced infantile convulsions and other disorders, and in 1878 was also the report of cannabis leading to seizure freedom in a 10-year-old boy who had focal epilepsy. In 1881, William Gowers, and this should be of great significance to the neurologic community because Gowers is one of our most famous historical figures in neurology, reported that cannabis had been recommended for epilepsy by Russell Reynolds in 1961 as sometimes, though not frequently, useful. And then he actually administered cannabis and wrote about this in many cases with the effect of delaying paroxysms and mitigating the severity in some individuals. In 1851, in the U.S. dispensary, cannabis compounds were suggested for several disorders, including neuralgia, depression, hemorrhage, pain relief, muscle spasm, convulsive disorders, and other ailments. And in 1860, the Ohio Medical Society on cannabis, the efficacy was claimed for infantile convulsions, epilepsy, and many other disorders. And then things changed, and I think we can thank my country for this. In 1911, in the setting of prohibition, Massachusetts, which Lisa and I was shocked by this. We consider our state kind of liberal. We're blue. Massachusetts was the first state to outlaw cannabis in the setting of prohibition, and the other states quickly followed marijuana prohibition laws. And in 1970, the United States Controlled Substance Act passed, classifying marijuana as a drug with no accepted medical use. So isn't that shocking? After thousands of years of evidence that this might be a treatment, suddenly in the setting and because of prohibition, it's decided not. But things have been changing in 1996, and I think this started all of this now concept of medical marijuana. In 1996, California became the first state in the United States to legalize medical marijuana, and earlier this year, it was legalized in 23 states, regulated at the state level, which makes it complicated and interesting, but difficult. And there kind of had been increasing anecdotal reports about the efficacy of medical marijuana, especially CBD-enriched formulations, in the treatment of refractory epilepsy. Now, I've never smoked marijuana, but I'm extremely interested in it. It's a complicated plant, over 500 chemicals. THC, it's the only plant that contains these cannabinoids. And what's interesting to me about it is our brains have receptors for cannabinoids. So why this plant has these chemicals that our brains have receptors for has been intriguing to me. THC is a cannabinoid. That's the one that has psychoactive properties. Cannabidiol has no psychoactive properties, and that's the one that's thought to be potentially effective in epilepsy. So about 2.5 years ago now, with this increasing anecdotal thing over the web, social media, people using this, a group of five academic centers, including us, got together with a company in the UK, GW Pharma, which many of you have heard of, that have products. They had a cannabidiol, and we decided to ask the United States government, the FDA and DEA, for permission to put kids on this to see if it was effective. In order to do this, I was allowed initially 25. I now have 56 kids under this IND. We had to write little stories about each kid to the DEA and FDA, showing that these kids were with the most highly refractory epilepsy we had. They'd been on 10 medications. Most had either surgery, had been on diet, had the stimulator, and still having seizures per day, showing these kids really don't have options. They need to have the opportunity to try this. Of that, because I had this big interest in TSC and epilepsy, I had initially had 5. Now I have 16 patients with TSC on cannabidiol. Under this expanded access IND, all of them, again, with the most highly refractory epilepsy of my epilepsy patients. And we have done interim analysis on 10, and this is going to be presented at the epilepsy meetings in a couple weeks. Average age is 11, kind of more boys than girls, many with the TSC2 mutation. And what is looked at in epilepsy trials now is called the responder rate. And that is what percentage of people have a 50% or greater reduction in seizures. That's a responder. And kind of then also obviously interested in side effects, because this is really safety, tolerability as well as efficacy. Found that there can be diarrhea, and that's because it's in an oil. So the more volume of oil, sometimes diarrhea. And then very important also to know is there can be significant drug interactions, particularly with clobazam, as well as valproate. And important in the United States to know, because many people are putting their kids on very different variations of medical marijuana, and a lot of these kids are on these drugs. And if they're not followed, levels aren't followed, then this isn't appreciated. The kids can have pretty significant difficulty with profound lethargy, change in liver functions, et cetera. But anyway, what we see is it can be really helpful in TS. And this is over the response rate of these different months. But I think if you look here at the 12 months, the fact that these kids, there's a greater 50 to 60% response rate. And again, remember, these are my most refractory epilepsy patients. So anything that can reduce their seizures by 50% to me is pretty wicked exciting. And one of the kids is seizure-free after 2 months. And this is a kid I've known on and off for years. She had epilepsy surgery with this years ago, moved away, came back about 1.5 years ago, and her brothers came with her. And her brother said, "You have to help Marissa. We've lost her." And at that point, Marissa was completely, basically non-interactive. She was having continuous atypical absence seizures. So we put her on the Epidiolex under our expanded access. And she's been completely seizure-free for 9 months. Now it's going on 1 year. And actually, she comes back now, you cannot shut the kid up. And so her mom is like, now she's really driving me crazy. Because she's like chatty Cathy. I like this, I like that, you know. But anyway, so it's been pretty incredible for her. And in addition to seizure control, we've had parent-reported improvements in alertness, verbal capacity, communication, vocalizations, cognitive ability, initiation of emotional and physical connections. Now, this you have to take very cautiously. Because one of the concerns about this is there's such hype in the United States for possible medical marijuana that we know could be a huge placebo effect. If I put my kid on this, I have such great hope that this is going to work, that I can see my child no longer be autistic, no longer be anything. And so that's why the randomized controlled trials are so important. But based on our stuff on the IND, on these TS kids, GW Pharma has announced they've filed with the United States, and these will be international studies, that there will be TSC-specific studies with cannabidiol. And they will be starting soon. And there is great interest. They have, they have talked to John about possibly there being a site in Australia. So I think you guys could be hopeful that hopefully there will be a site here for this study. The inclusion criteria will be a pretty broad age range, and I was really excited about that. That will include not only children, but also adults. Well-documented seizure history, diagnosed with TSC, stable on all medications, because when you go into trial, you want to see what your study drug is able to do. No changes during the trial. No medical marijuana or cannabis-based trials during the trial, so that makes sense. And then baseline to include greater than 8 seizures during a baseline period. The exclusion criteria, or the folks have had pseudo seizures, because it's going to be hard to track what's a real seizure and what's not. Illness or anesthesia in 4 weeks prior, surgery for epilepsy 6 months prior, if they're on felbutol, if they're on an mTOR inhibitor, and part of the reason for that is the mTOR inhibitors are currently in clinical trials for epilepsy. You cannot be on 2 investigational drugs at once. So even if a person is on an mTOR inhibitor for renal AML, that would exclude them from this trial. The topical rapamycin honestly should not, because that does not get absorbed. Hepatic dysfunction, suicidal thoughts, and that's true for any seizure trial right now, and then any use of recreational marijuana. And kind of what's going to happen with this is there will be a 4-week baseline, so folks will enroll in a baseline so you can track seizures over that time. 4-week initiation of drug, 12-week observation, and it will be a 1/3 placebo, 1/3 one dose of CBD, another third a higher dose of CBD. No one knows, we don't know, people don't know what they're on, and then at the end of that observation phase, anyone can go into open label phase, and then everyone will get drug. So again, these are the things that will be measured, but I think that they're, in the United States, and I know kind of increasingly around the world, there's a lot of interest and excitement, and this is not the silver bullet for epilepsy and TS. It's not the silver bullet for epilepsy in anything, but I think it's a very safe and well-tolerated medication, and I know it can be helpful to some people. And so with that, I'd like to stop and thank you guys very much.